Ladies and gentlemen, good afternoon. First of all, I would like to thank the organizer for their invitation to the EDIC conference. It's really a great honor for me today to discuss with you the place of medication in eating disorder, especially the place of medication in the treatment of anorexia nervosa and comorbid disorder. Anorexia nervosa, as you know, is among eating disorder and psychiatric disorder, the one with the highest mortality rate. Despite progress, treatments are insufficiently effective. And as Janet Treasure underlined, there is a necessity to increase access to treatment, to develop new treatments and new strategies to treat patients. Psychiatric comorbidities are the norm, rather the exception in people with eating disorders. The most frequent comorbidities are mood and anxiety disorders. And there is a need to better understand these comorbidities and to have recommendations to identify the most effective treatment for people with eating disorders and comorbidities. The Etiopathology of eating disorders is not totally understood. It can be modelized by a complex biopsychosocial model like this one, which was published in a collaborative transdisciplinary paper on the behalf of the French Federation for Anorexia and Bulimia Research Group. The clinical presentation of AN is also complex. It includes eating disorder symptoms, nutritional symptoms, somatic and psychiatric morbidity and comorbidities, social disability, and symptoms linked to the different developmental trajectories. All these elements contribute to the global clinical state. The treatment for AN targets all these elements. It is based on a transdisciplinary approach. The roots for this approach are the needs of the people with eating disorder. They need a treatment targeting symptoms and morbidity of eating disorders, from acute to chronic clinical state, combining nutritional, psychiatric, and somatic and psychosocial approaches. It's based on evidence-based treatment, but these evidence-based are frequently psychotherapy and less frequently medication. So comorbidities, especially anxiety and depression, are frequent and they are linked to a worse outcome in AN. So we need to identify effective treatment in this case. So I will focus here on this question. But medication is only a part of the global treatment. It is used to treat eating disorder symptoms, psychiatric comorbidity, and we have, in addition to use other medication to treat medical complications, but it will not be the theme of my speech today. So the objectives of my talk today will be in three parts. I will first speak of medication and do an overview of the literature. Then I will do an overview of the position of the guidelines. And then I will discuss how can we manage comorbidities with anxiety and depression in clinical practice in the real life. So for the first point, I will base my talk on the result of a multidisciplinary overview of published research about medication in AN. This work has been done by a multidisciplinary group of volunteers of the French Federation of Anorexia and Bulimia Group. So Since the 16th, nearly all psychotropic medication have been used to treat AN. All studies have got many limitations, and there are very few studies. I will summarize here the main conclusion of the overview. The aims of the trials were mainly to find medications that would cure AN, and they were based on different rationale, but one of them is the fact that these medications had side effects in terms of weight gain in other disorders. Then we had hypotheses about neurobiological etiopathogenic neurotransmitters involved, and we have now some hypotheses concerning abnormal function of neurohormone involved in the regulation of dimensions altered in AN. But to my knowledge, no study focused on the question of how to treat comorbid disorders in AN. And most studies we have are mainly focused on adults and not adolescents. Concerning antidepressants, we have studies that were focused on these drugs because of the clinical similarities between AN and depression with the symptom overlap, and because of hypothetical neurobiological similarities. The main outcome criteria studied was weight gain or maintenance, and the secondary criteria were eating disorder symptoms and psychological symptoms. The conclusion is that there is no impact on weight, and there is an impact on eating disorder symptoms or psychopathology that is not clear for these drugs. The only affirmative conclusion is that tricyclics and monoamine oxidase inhibitors have adverse side effect profiles such that they should not be used in AN. Concerning antipsychotics, we have nearly all the same reasons for treating people with AN, with an additional reason that is the hypothesis that obsessions regarding weight and body shape could be viewed as delusion ideas linked to dopamine receptors. There were also reasons linked to the possible efficacy of these drugs on hyperactivity, and the fact also that second-generation drugs also act on the salience network, which is impaired in eating disorders. The outcome criteria was the same than antidepressant, and the conclusion nearly the same too. Antipsychotics have no impact on weight gain compared to placebo, and their impact on eating disorder symptoms and psychopathology is not clear. The only antipsychotics which has small moderate effect is olanzapine for adults with a long duration of AN. So this atypical antipsychotic could also alleviate some symptoms such rumination, anxiety, but level of evidence are low. Concerning lithium, there is only one randomized control trial, and the conclusion is that it should not be used for anorexia. It can be only used in bipolar disorders. Many other drugs were tested, appetite enhancers and other drugs, but the conclusion for all these drugs is the same. The efficacy is not proved, and the safety neither. So, in 2011, the guidelines of the World Federation Societies of Biological Psychiatry conclude that the majority of the drugs used to treat AN are used off-label. But 10 years later, we are in the same situation. So, what can we say today? The discovery of psychotropic drugs have improved the outcome of the majority of mental disorders, except anorexia nervosa. Since the discovery of antipsychotics, nearly all psychotropic drugs have been tested in AN with no efficacy. Finding an efficient psychotropic drug in AM seemed to be the quest of the Grail. The quest for the Grail, excuse me. Why are we in this situation? As you all know, AN is comorbid with almost all anxiety and mood disorders and many other psychiatric disorders. And these comorbidities could differ profile in AN. Among persons with AN, the majority have at least one comorbid psychiatric disorders. It could be depression, generalized anxiety disorder, social phobia, OCD, or panic disorders, or bipolar disorder, or substance use disorder, or post-traumatic stress disorder, or autism spectrum disorder, or personality disorder. And finally, some have no comorbidity at all. Well, trials for the evaluation of, excuse me, I've got a problem with my computer. I cannot find, excuse me, just 1 minute. Thank you. I've got two screens and I lost my, okay. Trials for the evaluation of medication in AN generally include all types of people with or without comorbidity in different proportions, and the only comorbidity that are considered are substance use or suicidal risk, which are generally exclusion criteria. So, in trials evaluating efficacy of medications in AN, sampling probably impacts the results. This is due to the heterogeneity of the sample in terms of comorbidity, combined to the fact that acute or chronic forms of AN are considered together, and that malnourished persons are pooled with normal weight persons, and the low compliance of persons with AN is also a problem. The consequence is that the results are not conclusive. However, I do not know any studies to date that has addressed the question of efficacy of psychotropic medication for persons with AN and a comorbid depressive or anxiety disorder. Future research should address this question and should compare persons with comorbidity that are treated or not by medication. But this type of research is challenging because inclusions are difficult. So what can we do? I think we have to change the paradigm. In fact, we have not to evaluate the drugs in a heterogeneous sample, but we have to propose to evaluate the strategies we use in the real life practice as it is done in cancerology. So if you refer only to the evidence-based elements, psychotropic drugs should not be prescribed in AN. But there is a huge disparity between research conclusion and clinical practice in the treatment of AN, because both in adults and adolescents and in many countries, medications are used in case of symptoms of anxiety or depression or in case of comorbidity. So we have to move from evaluating antidepressants in problematic trials to evaluating structured complex strategy used in clinical practice as it is done in cancerology. In fact, we know that psychotropic medications are used in people with very high anxiety and depressive symptoms during their treatment. Subjects under psychotropic medication have at admission and discharge higher level of depression or anxiety than those without such treatment. And in addition, people treated with medication have generally more severe eating disorder symptoms and lower BMI. You can see this on this schema. You will learn some words of French because entrée means admission and sortie means discharge. What you can see is in blue the level of anxiety and depression of people without medication, antidepressant or antipsychotics, and in red, people who have got this treatment. What you can see is that at admission and discharge, all people with medication have higher level of anxiety and depressions. And we can see that the evolution of both groups is parallel. That means that people who are on medication improve by the same amplitude in comparison with people without medication. But they still with higher levels of anxiety and depression during all treatments. That do not mean that medication is not useful. That only means that they do not have the same profile. So, what can we do? Let's have a look on the international guidelines. We will consider all these guidelines and their variation across 2 periods. First, at the beginning, in 2004, the Australian guidelines indicated the use of antidepressants for the symptoms of anxiety, depression, or obsessionality, but they do not precise when and how. And they also propose antipsychotic for hyperactivity or obsessional thinking, with no more precision. 10 years later, they propose to treat comorbid conditions if these comorbid conditions are not simply linked to starvation, but they do not give any more informations. And they give some information concerning side effects. If we now consider the APA guidelines, they mentioned in 2006 that psychotic medication should not be used as a sole or primary treatment for AN, and I think we all agree with that. But they also mentioned that you can treat symptoms which are associated, such as depression or anxiety symptoms, if they did not disappear after weight restoration. We did mention all these elements also in the HRS guidelines in the same way and with no more precision. In Germany, they mentioned that antidepressants do not improve the course of AN, but they say that occasionally medication are used to treat comorbid depressive symptoms with no more precision. In the old version of the NICE guideline, we find the same informations, and they said that comorbid conditions such as depressive or obsessive compulsive features, as they may resolve with weight gain alone, should be treated with caution. But this guideline, the last version, is much more precise and consider that we can treat comorbid mental health problem, taking into account different aspects, and refer to the general guidelines of this specific mental health problem for further guidance on treatment, which is that is the first time that guidelines mention this type of recommendation. In addition, they mention a lot of elements about the side effects and the security for the use of this medication, and they mention the possibility of using this medication in case of medication misuse. So, how do we do now in clinical practice in real life in order to manage the comorbidity or the symptoms of anxiety and depression in AN using both evidence-based data and the elements of the guidelines? Well, there is a discrepancy, as I said, between evidence-based data and clinical practice for the use of psychotropic medication in AN. There is an important use of the guidelines in this sort of case because they give both elements about evidence-based data, but general guidelines add to evidence-based consensus-based elements. These elements are based on the experience of the expert, and they give some recommendation to treat patients with comorbidity or symptoms of anxiety or depression. But the guidelines are not very precise. Though, generally, what do we do? What I do is to refer to my experience. But what is experience? Experience is the result of a complex combination of elements. It's based on core beliefs derived from different sources, including, of course, evidence-based data, guidelines, but not only, in fact. Our experience is also impacted by the healthcare organization, the psychiatric theoretical orientation we have, and the good or the bad experiences with one or several patients we had. So, what can we do in real life practice? First, we have to consider concurrent symptoms of anxiety, depression, and obsessionality in the clinical presentation of the patient we are treating. Symptoms are really frequent, but they do not always indicate a disorder. It's not easy to distinguish between anxiety or depressive disorders and symptoms in anorexia nervosa. So, there is a consensus to defer medication if possible until patients' weight has been restored. Is it okay for you, this consensus? Yeah? Okay. It's not for me. Because in fact, weight restoration can take years. And sometimes there is an emergency to treat. So, we have a logical approach generally. That's what you do, that's what I do. We try to answer the question of how to manage co-occurring anxiety or depression in eating disorders. And when we have understood what is the nature of the symptoms or if there a comorbidity, then the link between depression and anxiety and eating disorders guide us to the solution. So, the link between AN and depression or anxiety has been described in various contradictory ways. For example, AN has been considered either as a form, a consequence, or the cause of depression, anxiety, or OCD. To understand the links between depression, anxiety, and AN, we have to separate all the elements that are in fact tangled up in clinical presentation of persons with AN. First, in this case study, it's well known that semi-starvation causes anxiety, depressive symptoms, including irritability, depressed mood, anxiety, and difficulties in concentration, obsessions and compulsions about food. In addition, in clinical studies, it has been shown that nutritional status is linked to anxiety and depressive symptoms in AN. The more the patient is malnourished, the lower is the BMI, the higher are the anxiety and depressive symptoms. In line with this, the depressive symptoms caused by malnutrition in AN are mainly mood disturbance or vegetative symptoms. The anxiety symptoms caused by malnutrition are mainly related to food. It includes fear of eating with others and/or obsessions and compulsions about food. The depressive symptoms linked to malnutrition do not include the most severe symptoms of depression, such as self-depreciation, negative self-esteem, culpability, or suicidal ideas. The symptoms of anxiety and depression linked to malnutrition do not include the symptoms of anxiety and depression due to malnutrition should not allow a diagnosis of anxiety or depressive disorder. Secondly, there is an overlap between AN and anxiety and depression symptoms, but these symptoms are not sufficient to lead to a diagnosis. For example, there is often a fear of eating with others, obsession or compulsions about food, or weight and appetite variations. Third, eating disorders and anxiety or depression can also be comorbid. By comorbidity, we mean that at least one anxiety or depressive disorder is concurrently present with eating disorder. We mean disorders according to DSM criteria. For example, AN and anxiety or depressive comorbidity is not always easy to diagnose. As we have mentioned, there is an overlap between their symptoms. It's for depression, for example, very easy to find enough criteria to diagnose the disorder in case of AN. In addition, in the literature review, we have underlined that in AN, the lowest prevalence of depression were observed in studies removing the loss of weight and the loss of appetite criteria for the depression diagnosis. Despite these elements, anxiety or depressive disorders are really frequent in AN and can include prior to onset, concurrent, or post-onset disorders during a lifetime. The relative chronology of the onset of anxiety or depressive disorders allow us to differentiate three types of AN. The first is preceded by anxiety or depressive disorder. The second is concurrent with these disorders. And the third is followed by anxiety or depressive disorder. We have hypothesized previously that these three types of AN profile could be different clinical profile of possible comorbidity. Anxiety or depressive disorder preceding eating disorders can distinguish severe form of AN. Concurrent disorders should be at least partially related to the malnutrition artifact mentioned above. And finally, anxiety or depressive disorder posterior to eating disorders could be the consequence of chronicity, the consequence of malnutrition the consequence of recovery from eating disorders. In summary, co-occurrent anxiety or depression in AN is a sort of chimera. Chimera is a mythological animal composed of the part of multiple animals. Anxiety and depression in AN is composed of tangled up symptoms related to malnutrition, overlap of symptoms, and comorbid disorders, either anterior, simultaneous, or posterior to AN. The composition of the chimera varies with each individual, and in each individual can vary according to time. How to manage anxiety or depression depends on the composition of the chimera. If you face co-occurrence of anxiety or depression symptoms in AN, you have to evaluate the possibility that these symptoms are at least partially due to malnutrition or eating disorder symptoms. In addition, you have to investigate if there is a comorbid anxiety or depressive disorder, a current one. If it is the case, investigate then the chronology of onset before AN, concurrent to AN, or later. In the later case, is it concomitant to renutrition or after a long chronic evolution leading to social disability? Last, you have to collect individual and familial history of past anxiety and depression disorders and individual developmental history to look at the traumatic events. At this point, you have drawn a portrait of the chimera that will help you to manage anxiety or depression. In addition to the composition of the chimera, the treatment will depend on the age of the patient, the urgency of the situation, and the level of care will depend on both the comorbid anxiety or depression severity and the eating disorder severity. Inpatient treatment will be required if there is a life risk or if a patient cannot receive structured treatment at home. Well, I would like to underline that the risk of suicide is high in anorexia nervosa patients, especially if the patient suffers from a co-occurrent depression or during the switch between the restrictive form of AN to the purging form, and even more if both conditions are associated. In addition, suicidal risk is higher in case of anxiety disorders. So, managing co-occurrent anxiety and depression in AN will include the specific treatment we mentioned before, including all the necessary elements. And if there is no emergency, one can wait some weeks in order to reevaluate later the necessity of specific treatment for anxiety or depression. Anxiety and depressive symptoms can be dramatically reduced by the specific treatment of the eating disorder. But conversely, if there are not a specific treatment of anxiety and depression, might be discussed with the patients and the medication should be proposed. So, you will have to specifically treat anxiety and depression if the specific treatment of AN failed to treat completely the anxiety or depression after some weeks of treatment. Woodside suggests 6 weeks in his review paper. You also have to begin a specific treatment in emergency case if anxiety or depression are very intense and if all severe form of depression or anxiety have preceded AN, or if AN is resistant to the global treatment. In this situation, you will use specific treatment of anxiety or depression, but you do not have evidence-based about it. How will you do with the medication? First of all, I would like to consider medication, including antidepressants. Medication have usually been evaluated, but no study, as I've said before, have evaluated the effectiveness of this medication specifically on anxiety or depression in AN. So, you have to discuss all these elements I detailed before with the patient we treat. And you have to have a general discussion with the patient to discuss side effects, risk, benefit, alternative, and the fact that to be efficient, a medication has to be taken and it has to be observed. So you have to mention them that if they purge, they have to take the medication after, and they have to mention that they have to take the treatment if they want it to be efficient. And all these elements have to be discussed because of legal obligations, but also in order to improve therapeutic alliance. What we can say is that you must not use tricyclic, but more SSRI. And generally, you use them after nutrition, but some exceptions exist. These exceptions are the emergency, and you have, in summary, to use medication if comorbidity is observed. You first evaluate the chimera, then you initiate the global treatment, and if it's inefficient, or if there is an increasing of symptoms, you discuss medication. If comorbid anxiety or depressive disorders are observed, you have to evaluate the necessity of treating in parallel of the global treatment. So we can summarize it like that. If you have anxiety and depressive symptoms simultaneously to AN, you do the portrait of the chimera. If you have got an emergency situation, you have to treat. If you have a low intensity or no emergency, you wait 6 weeks. And if symptoms disappear, that means that they are secondary to malnutrition. But if it's similar, or if they increase, or if there is a comorbid diagnosis, you have to discuss with the patients the indication of medication. So, in conclusion, we need new approach for eating disorders, and especially anorexia nervosa. Perhaps the question of evaluation of appropriate strategy for the treatment of depression and anxiety could be a lead. And perhaps also the treatment by estrogen could be another one. To conclude the discussion, we have got the treatment of anxiety and depression in 8 patients is guided more by expert consensus and evidence-based data. The existing weak data mainly focus on adult patients, though new research is needed, and especially in the population of adolescents. I thank you for your attention, and I will answer to your questions later. Thank you. Bye.